Dear audience, I would like to present my 3 months progress. My name is Sára Borbála Szabó. The title of my PhD thesis is Investigating the Risk Factors and Therapeutic Approach of Medication-Related Osteonecrosis of the Jaw. I'm an oral surgery resident and a first-year PhD student. My supervisors are Réka Fazekas and Fruzsina Kis. My scientific methodology supervisor is Lorenz Frivalski. My vision is prolonged survival and improved quality of life in patients receiving bone-modifying agents. My mission is to estimate the risk and the rate of medication-related osteonecrosis of the jaw in patients receiving bone-modifying agents. I have 2 specific goals. The first one is about the efficacy and safety of combination treatments in bone cancer patients. The second one is about the resolution of medication-related osteonecrosis of the jaw. We started the first project this September, the second one this November. The title of my first project is Investigating the Efficacy and Safety of anti-angiogenic and anti-resorptive treatments in bone cancer patients. A little bit about the background. Approximately 2 million new patients have been diagnosed with malignancies in the USA in 2024. With the prolonged survival of cancer patients treated with targeted therapies, including anti-angiogenic drugs, bone metastases frequently occur. Anti-resorptive drugs such as bisphosphonates and denosumab are used for the prevention and treatment of pathological fractures, bone pain, and hypercalcemia. As I'm training to become an oral surgeon, I'm concerned about the oral complication caused by these drugs, which is medication-related osteonecrosis of the jaw. This is a severe, painful condition, and it can decrease the patient's life quality. The incidence of this condition is about 1 to 10% in patients previously exposed to anti-resorptive agents. With the addition of anti-angiogenic drugs, this percentage can increase. However, there is a lack of information in the literature regarding the development of this condition and the overall survival. So this leads us to our aim, which is to reach a definitive conclusion on the efficacy and safety of these combined treatments in comparison with their separate administration. Our clinical question is, does combination of anti-angiogenic and anti-resorptive therapies increase the efficacy without enhancing the side effect profile in bone cancer patients? Our population is bone cancer patients, primary and metastatic. Our intervention is the combination therapy. Our first comparator is anti-resorptive therapy alone. Our second comparator is anti-angiogenic therapy alone. We have 2 main outcomes. The efficacy outcome is about the overall, the progression and fracture-free survivors. The safety is about medication-related osteonecrosis of the jaw, gastrointestinal, and skin side effects. Our hypothesis is anti-resorptive and anti-angiogenic therapy in combination improves the overall survival and does not cause any more side effects. Our clinical implication is better survival and improved quality of life in bone cancer patients. We have found 2 previous systematic reviews and meta-analyses, but we haven't found any Prospero registrations. Here you can see my key articles. The intervention is the combination therapy. The comparator is one of the anti-angiogenic or anti-resorptive drugs. In the outcome, you can see they all check the incidence and the overall survival. We conducted our systematic search on the 25th of November this year. We have conducted this in 5 databases. Here you can see after the duplicate removal, we have over 3,000 results. And now we are at the title and abstract selection, which hopefully will end this week. The title of my second project is Investigating the Resolution of Medication-Related Osteonecrosis of the Jaw. This is a registry analysis project which I'm sharing with Kitty Hall. A little bit about the background. As I mentioned in my first background, medication-related osteonecrosis of the jaw is a severely painful condition, and we can characterize it with exposed bone, or bone that can be proved through a fistula intraorally or extraorally, mucositis, and impaired wound healing. The management of this condition is really challenging and case-dependent. Here you can see 2 main ways, the conservative and the surgical way. However, 20% of patients remain with persistent symptoms, so we can say that early diagnosis and prevention are key. This leads us to our aim, early diagnosis and control of the course of the condition. Our clinical question is, what are the optimal treatment paradigms in different stages of medication-related osteonecrosis of the jaw? We have two populations. The first one is patients with high dose of bone-modifying agents. The second one is with low dose of bone-modifying agents. The first exposure is the conservative treatment. The second exposure is surgical treatment. Our outcome will be the time course and rate of resolution of medication-related osteonecrosis of the jaw. We have two hypotheses. The first one is the rate of resolution of medication-related osteonecrosis of the jaw is related to the severity and stage of this condition. The second one is that the rate of resolution of medication-related osteonecrosis of the jaw is inversely related to the presence of oral risk factors that preceded the event. And our clinical or research implication is characterizing treatment patterns for medication-related osteonecrosis of the jaw to improve the patient's quality of life. We have an inclusion criteria which includes any able-bodied patient over the age of 18 with newly confirmed medication-related osteonecrosis of the jaw. Our exclusion criteria contains patients under 18 years of age and the patient withdraws their voluntary consent during the study. We are planning this registry in multi-centers in Hungary, so it will be a national registry. And here you can see the summary about our two projects. We are planning to submit the first one next year in September, the second one hopefully in February 2027. And I would like to thank you for your kind attention with a quote from Charles F. Kettering: research means that you don't know, but you are willing to find out.
Thank you very much. Any questions?
Very nice presentation, thank you. So my question would be about the safety outcomes in your first project. Could you specify the gastrointestinal and the skin side effect that you mentioned?
Yes, thank you for your question. As I know, for the anti-angiogenic drugs, the patient can develop gastrointestinal perforations, fistulas, diarrhea, and they can also develop dry, itchy skin. And patients who are taking anti-resorptive drugs, they can develop gastric ulcers and esophagitis.
So thank you for the presentation. I would like to ask a question about the first project. Do you plan to investigate a fixed combination of the two drugs or group different active ingredients together and investigate like that?
Yes, thank you for your attention. Thank you for your question. In our PROSPER registration, we included many types of anti-angiogenic drugs, for example, tyrosine kinase inhibitors, monoclonal antibodies. So we are planning to conduct this investigation with all of the anti-angiogenic drugs included. So we are not planning to do any subgrouping between the anti-angiogenic drugs.
And do you plan to subgroup the anti-resorptive drugs or the administration methods?
Yes, we have also included denosumab and every known bisphosphonate drug that is used in the practice.
Thank you.
For your presentation, I think you focused on the treatment. But what if I have to use these drugs due to my medical condition? Can I prevent some way to develop this disease or not? What is your opinion?
It is really important to identify patients who are at risk developing this condition. As far we know in the literature, patients who are taking this parenterally and they have a long duration of this administration and also a high dose. So it depends everything, like I said, and also the type of drugs you are using.
Okay, thank you very much.
So congratulations to your presentation. Actually, I'm a clinical oncology resident, so we have a lot of patients who receive bisphosphonates and these drugs. So I wonder what is your suggestion, how we should educate these patients, because we try what they should pay attention, what we should pay attention.
Thank you for your question. I think before initiating any therapy, you should inform the patients about the risk developing this condition, and also you should send them to dentists or oral surgeons, and they will perform a thorough oral examination, and then after they have extracted maybe the problematic tooth, you can start the treatment for the patient.